My sound's a little weird in my head. Hello, hello. What's going on, everybody? I'm making sure I am. Can you guys hear me okay? My sound was a little weird in my head. Okay. Hello, hello. Okay, I'm seeing I've got some sound. Roel, what's going on? Can you hear me okay? Is everybody hearing me all right? Tom, my brother. Dude, it was so good to meet you last week, man. It was so, yes, I did. Yes, I did. I have not dove into the article yet, though, but I got them in my email. I'm going to read it tonight. I promise. Thank you. Thank you. All right, let's see here if I'm getting any feedback, if I'm way off. Am I sounding okay, Tom? I got a little different mic scenario. Okay, cool. Can you guys hear me okay? Oh, sweet. Thank you, guys. Thank you, Stokes. I see you guys. I see you guys on Instagram. It'd be very interesting how it shows up on Instagram. We're on vertical over there. A little muffed, huh? A little muffled. Team, can you check me my my audio? We're letting some people in here. Jay, I see you. Haley Lynn, what's going on? Great to see you. All right, cool. All right, just keep me in the loop, guys. If I'm starting to sound bad, then I can fix it. Jerry from the UK, hello. How are we? Great to see you. I'm looking at you guys too on Instagram. We're going to let a few more people coming in here. As you guys know, I'm with my brother tonight. Andy Rogers is going to be answering some questions. We're going to be here till 8 o'clock or so. Danny, good evening, man. Thank you for being here. It makes me so happy to see all these familiar faces each and every week. This means the world to me. I really appreciate you guys. Thank you, Roel. Thank you for the, so sound check is good for Roel. All right, we've had some cold weather. I see Tom got snow. I've had some really cold weather up here in East Tennessee. Roel, are y'all even cold down there in Texas? All right, I'm going to real quick go over a few things that went out today. As y'all know, we send out Performance Weekly every single Tuesday at 3 p.m. Today, this is just so cool. I don't know if anybody got the chance to watch this. We went live on Facebook on Friday of last week, and then we recorded a Common Sense MD episode with it. And that's Yael Schumacher. She is an 11-year-old prodigy pianist. Came to the studio, played a couple songs that she's going to be playing at the Carnegie. Gosh, I think it's later on this month. If you have not watched that, please do. It is incredible. She's incredible. Huge shout out to Carol Stone, her teacher, and the whole Schumacher family. It's just amazing. She came from the Ukraine, got a sponsor who's a friend of ours who came over and watched this little mini concert. They're raising money for her family to get to see her at the Carnegie. It's just an amazing story. I really hope you'll watch it. It was special to us, that's for sure. And then we have a new series on the Performance Medicine podcast. It's called Keep It Simple with Bo McGregor. We did an episode today called Navigating Midlife Health Challenges. As you might guess, a lot of this was geared towards me. nearing 40. So Bo largely helped me out with this episode, but I have such a good time talking with him, keeping things simple. We know that this, integrative medicine, functional medicine world can get complex, and Bo does a fantastic job of breaking it down into the absolutes, the things that really matter. And this one was no different. We talked a little bit about like what to track, what not to worry about as much. So huge shout out to Bo McGregor. I see my brother's in the building, Andy Rogers. I'm going to bring him up here in just a second. Yeah, Danny. That's what amazed me the most. I'm going to put that up from Danny. She's 11. She learned English 3 years ago, and like came over not speaking any English, and she was like talking to my brother. She just so mature. It was just such a blessing to get to hang out with her. Thank you for watching that, Danny. All right, is Bro ready? No, he's not. He's not ready. He's not ready. I love that. He's getting hair and makeup right now. All right, he's ready to roll. All right, guys, if you have questions for Andy, go ahead and put them in the comments. Let me know if my sound is muffled. We'll fix it as soon as possible. Let's get him on stage.
Can you see me?
Yes, I can see you. Can you see me?
Yeah, it feels like my screen is split.
Yeah, there's two different views, but you're the only one seeing that.
Oh, I'm the only one saying that. Okay, no, if it looks normal to you, it looks normal to me. It just, I got more going over there.
Can we get some clarification, guys? Do we look normal? Can we just clarify that?
Normal too. I'm having a little bit of a I'm doing like a little back combing, trying a little middle part. So
I like it. I like it.
Trying to do some new stuff. So we'll see.
You're also looking very festive, and I'm all for it. I'm here for it.
I know. Ben, we're not going to worry about where we're going to get Christmas sweaters whenever the circus runs out of town. We're not going to. We're not going to. No. Ben, how's it going? I feel like I've seen you. You know what? Like, I feel like we've hung out recently. You came over to the house. Ben came down to Knoxville. We did a little bit of a Friendsgiving, an early Friendsgiving. It was really great. Yeah. It's awesome.
It was amazing. I had such a good time over there in Knoxville this weekend. Thank you for the hospitality. Huge shout out to Ernie. Thank you, Ernie, for letting me stay with you guys and hang out. Y'all are the best, and your friends. I want to give a shout out to the crew.
Oh, they're fantastic.
They're fantastic.
They're so much fun. It's a good group down here, and very smart group, very fun group, festive group, and it's great.
I'm gonna put this up from Danny. Danny saying you could be bald like us old men.
Danny, we don't believe in the B word in this family, okay? No, we don't. We don't use that. We don't use it. It's really hard for us to hear that kind of language spoken so freely. Miss Edna, oh my God.
It's so
Edna's
good to see you,
house. Edna Yates. Oh, too, Edna, thank you for my Halloween stuff.
Yeah.
I just got my Halloween. I have Edna always celebrates the holidays with us, and we just have so much fun.
Sandy, so good to see you, Sandy.
Yes.
Thank you for being here. We got Wes in the building. We got Wesley and the crew.
Rachel, Rachel, I have something to text you later, and it's hilarious. Just prepare and make sure you send me a text to be like, hey, remember you're going to tell me something funny? It happened at 3:00 today, and I was like, I need to text Rachel, and I forgot, which sounds very classic of me to do that. So, yeah.
Real quick, I see Chris is in on Thanksgiving, not on Thanksgiving, on Instagram. Kendra's in here. Thank you guys for being with us tonight. I'm looking over on Instagram as well. And I want to real quick, can anybody, cool. And you're going to see Sandy here soon. Sandy's coming in shortly.
Great, Sandy. Amazing.
Thank you, Sandy.
Oh, yes.
Are we delayed? For those of you who are with us each and every week, do we sound delayed? Are we delayed on y'all's end? I just want to double check me. just to make sure. If we're not delayed on y'all's end, then we're going to keep rolling and start with these questions here that came in throughout the week. Let's see. Thank you, guys. Thank you. Okay, cool. Thank you, Roel. All right, Ange, you ready to roll? Thank you, Tom.
Are we in? Yes.
All right, let's do this. Actually, we got 20 something people here real quick. Before we get started, Ange, I'm just gonna I want to recognize if we have any veterans in here. I want to recognize you guys and thank you for your service. Today is Veterans Day. Huge shout out to all the veterans. If you know somebody, my best friend Kyle is a veteran. I got to hear him speak on Sunday, which was amazing for Veterans Day, talking about his experience. I just want to thank you guys. Thank you for your service. Thank you all for allowing us to be safe here at home. And if you have somebody that you want to lift up, put their names in the comments, and I'll make sure to mention them tonight. Robin, I see you.
That's so nice, Ben. Look at you.
All right, we're gonna get rolling here. Thank you, guys, Leanne. Thank you, Leanne, for that. Thank you, Ivy. And yes, if you have a loved one to someone super close to you, it's a veteran, put their names in. I want to make sure we recognize them tonight. All right, Ange, you ready to roll?
I'm ready. Ben, I was born ready. I feel ready. Robin was with me and she prepared me for all these questions today. Anytime I'm with Robin, I'm like, I need to impress her. What can I say that's smart around Robin? And then sometimes when I get something right around her, I'm like, ooh.
a little like you stick the chest out just a little bit, you know. It's like, huh, okay, all right, rock on.
Sometimes I feel like Romy and Michelle when Michelle starts to talk about the glue on Post-it notes and all of a sudden she just starts saying the right term for it. Look, oh, okay, I guess you did really invent Post-it notes.
I want to put this up from Robin. Thank you, Robin, for this. A huge shout out to Aaron. Aaron is with Robin right now, Robin's husband. Aaron, thank you for your service, man. Thank you for watching the show as always.
Yes.
We love you.
Oh,
we
absolutely.
Love you. Thank you so much.
If you want to guarantee a good time, Aaron.
He's the man. He's the man. All right, guys, we're taking questions tonight. If you have questions for Andy, go ahead and put them in the comments. I am going to start with a few that came in through email today. And here we go. Let's get started. Andy, you ready?
Ben, I couldn't be more ready than how ready I am right now to answer these questions. I cannot wait. Ben, I've been looking forward to this time we get to spend together. I'm sorry. I'm sorry.
This is bro time right here.
This is bro time.
All right. It has been recommended by my husband's doctor in another state that he have a PSMA. He's previously had the Tulsa treatment for prostate cancer, and his PSA keeps increasing. Tested quarterly for 2 years since treatment. He shows no cancer by MRI in the prostate, so they're wondering if perhaps there's activity in a lymph node. Goes on to say, I've contacted HMG and JC, and they told me none of their offices do PET scans and believes we would need to go to a hospital in the area to have that test. So this is seems to be a Tri-Cities listener. Do you have any good recommendations for this PSMA scan locally, or should we just go out of the area? And if so, do you have recommendations for where? Real quick, Ange, what is a PSMA? And then we'll get rocking.
Okay, so yeah, there's a lot of good words. Like, there's a lot of good words in this question. I'm sorry he's experiencing this. First up, that's never fun to experience. Prostate cancers generally are very slow growing, so it's a little bit PSAs and prostate cancers and digital rectal exams and how you do that. The times are changing, so the testing modality of what you're talking about in here is really important for people to know. Will you go back in the question a little bit? Did she say MRI?
Yes, let me see here.
Are you able to go back?
I am.
Because that's important to know. Because PSMA, prostate-specific membrane antigen, to my knowledge, and an MRI guided biopsy. So MRIs are going to show, basically, it's how do we scan a really difficult organ to scan and see what's on it? That's the whole thing about cancers. PSA, just PSA, prostate-specific antigen, not prostate-specific membrane antigen, is a blood test. So there's a blood test called PSA, which also has free PSA and percentage free PSA. PSMA is a prostate specific membrane antigen that's by a PET scan. So a PET scan, there's a lot of P words, is a positron emission tomography, I believe, is PET scan. Basically, you put radioactive material into your body and see if there's a lot of activity. I believe it's actually sugar that they put a radioactive isotope on it so that it lights up on a scan. So the difference between an MRI and a PSMA PET scan, which is different, PET scan's just going to be a PET scan. That's just going to be where is cancer in the entire body. PSMA is where is it specific. It's going to specifically pick up a prostate cancer that could metastasize and go to the lymph nodes near the prostate. So that's kind of where we're at. There's 3 different tests: MRI, PSMA, PET scan, and PET scan. And then
Okay.
I've brought up a 4th one that is a blood test, because she brought up, if you go further back, she brought up that there's been elevations in PSA, which is a blood test. And also, too, was there something called Tulsa in there?
Yes, he's previously had the Tulsa treatment.
So you are bringing up all these are, this is an amazing question because it has all the acronyms. Tulsa is transurethral ultrasound ablation, I believe. So they take this wand and they go through the urethra and basically heat the cancer if it's a very low grade cancer that is near where it can be heated and destroyed. So basically, instead of taking the entire prostate out for a prostate cancer, which can have really difficult side effects with libido, sex life, with testosterone, um, that even to urination problems because the structure's removed. This is a minimally invasive treatment for prostate cancers in comparison. So that's what the Tulsa is. So we have Tulsa, PSA, PSMA, PET scan, and MRI guided biopsy, or MRI to see if there's cancers. So it's saying on this question that the MRI is not showing anything, which is good. So usually MRIs are going to pick up something, but something's around, could be around the lymph nodes, which is why the PSA keeps creeping up. One idea is that maybe since there's been treatment there, that it might not, the PSA might not be reflective of cancer, but it could just be reflective of the prostate being upset. PSA does not always mean cancer.
Okay.
I find that it's one that's at least a flag to make you look further. And we usually like to do MRIs after an abnormal PSA, which you have to have a very specific MRI specific to the prostate. I think a PSMA PET scan would be a good idea. I don't know specifically in the Tri-Cities where it would be, but I do know 2 institutes. This is the actual answer to the question. One is Dr. Bush in Atlanta. Ben and I know this. Living with Dad, you kind of know where he's going to go if something goes wrong, and he's going to Dr. Bush if something happens to his prostate. Dr. Bush, Busch in Atlanta. He's been in the business for a long time, so I don't know what his contingency plan is or how long he'll keep practicing, but he's very good. The next I would look up is Sperling Institute in Florida, Spurling. I have had a patient go there who had cancer and literally got it removed, came right back and got a testosterone pellet, and the Sperling Institute told them to do that. So
Wow.
they're very progressive in what they believe hormones can do for the prostate, and they're very minimally invasive. So I feel like if it's me and I don't know what's happening and I need to really check this out, I'm probably going to Sperling Institute, or I'm going to Dr. Bush in Atlanta. So those would be my 2 suggestions. We do make those referrals. I believe Sperling Institute, you might not even need a referral. Um, but that might be a little bit more specific treatment to prostate. But that's important information for people to know what all these different tests mean. So if you're interested in getting prostate really checked out because you have a hunch or something, if there's symptoms, if you're having difficulty with urination, PSA is really climbing, and you want to take a further dive into it, MRI is the next step. Then two, if some sort of cancer is involved, usually cancers in the prostate are very slow growing. You usually die with prostate cancer, not from it, is usually what they say, but that's not true for every type of prostate cancer. It depends on a Gleason score, which can rate the prostate cancers. From there, you would go to see, has this cancer spread to anywhere else in my body, which would be a PET scan or a PSMA PET scan specific to the antigen associated with prostate. And then two, the TULSA is a treatment that they do for a localized tumor found on the prostate. That's a really phenomenal question.
Yeah,
Sperling Institute, Bush.
and thank you for that answer, Andy. Like that went through, the different types of tests you can do. If anybody knows anyone who's going through this process with their prostate, tell them to listen to that clip right there from Andy that goes through the different avenues you can go through. So Andy, thank you for that.
You're welcome. You're welcome.
If you guys have any questions around that, if we need to go give any more context, let us know in the comments. I'm going to keep moving here, Ange, and go to a calcium score test, or sorry, question. My husband has had a high calcium score and follow up with a stress test. It did not indicate any blockage. He has a friend in Atlanta who had a CTA coronary scan after a high calcium score, and blockages were found in 3 arteries and significant enough that he needed bypass surgery as opposed to stents. He, like my husband, had no symptoms, just the high score. So do you think it would be advisable for my husband to have a CTA, a CTA coronary scan? And do you know if this procedure is even available in the Tri-Cities?
Yes, these questions are very thorough, and I appreciate these because it allows anyone listening to really get more information about details. We're talking about the heart now, down over to a different organ. The answer to this is yes, they do, and yes, he should. Absolutely, yes. So it depends on how high the calcium score was. Anything really over 200 to 300, we like to send to cardiology. And if they can't really find anything, sometimes you can say that's fine. But this is a very interesting finding. So what is happening is that there's 2 different tests we're talking about, a CT calcium score and a CT angiogram or angiography. So the difference between the two is that a CT calcium score is only going to detect hard calcified plaque, a CT calcium. So it's going to detect plaquing that is hardened and stable. What a CT angiogram is going to do is it's going to take fluoroscopy. So it's going to shoot dye and it's going to see how patent your arteries are, and it's going to detect soft plaquing. That's to my, I believe I think they inject dye. I need to make sure. Yeah. It's got contrast dye in it. So it's almost like a cath. Like a cath is going to go through, shoot dye through your veins, or shoot dye, and it's going to go through your arteries, and it's going to show how open and patent those are. CT angiograms can do the same thing. It's going to tell you soft plaque. So soft plaque is different because it's more vulnerable. It's able to loosen and move in your body and cause an occlusion or an embolus. So those are not good. So this is to say, yes, absolutely. You can have no symptoms. Cardiovascular disease is finicky, where you might not have symptoms and there could be something there and blockages. What we don't want for the heart is for there to be roadblocks. That's it. You don't want roadblocks. You want nice open arteries. You want the electricity to be working well. You want it like a really well-run city that's not overcrowded and forgotten or has too many people in it. So you want Knoxville. I
For
think
now.
Knoxville's great right now, but
For now.
we're about to need a CTA on Knoxville to make sure that there's no soft spot. We only want hard plaque. So too, the difference, so with scarring, with a score on a CT calcium, it's anywhere from 0 to over 1,000. So there, you can have a lot of plaquing. What it doesn't detect is if it's inside the vessel or outside the vessel. So you can have a high CT calcium score with none of the plaquing inside the vessels, no occlusion, no blockages. A CT angiogram to me is just a little bit more specific. I'm almost positive HMG does it. I know Ballad does it at the, I think, is it CVA? It used to be called
Yeah,
CVA.
it is. Cardiovascular Associates.
Yeah, so I know they do it. I know we even have someone, Ashton, our Johnson
Yeah.
City providers, worked in cardio for years, and we've talked about CT calciums and CTAs. So the difference between the two is that you can see hard versus soft plaque with the CTA. I think CTA is a little bit more specific. You can rest a little bit easier if the CT calcium score is 0. So if it's a 0 CT calcium score, we can I had a patient today, 5 years ago, CT calcium score 0. This year, calcium score 0. She's most likely doesn't have heart disease. So if those are nice and low, that's good. We usually don't refer out to cardiology. We use minimal, moderate interventions like aspirin, pycnogenol, omega-3s. If we have a lower CT calcium score, sometimes EDTA or L-citrulline. I believe Citracel is a brand that has L-citrulline that can help almost get some of the calcifications off and lower a CT calcium score. This is also important if you're taking vitamin D. You want to have K2, which allows calcium to not stay in the arteries, but to go to the bones. Stress test, what that does is it puts you either on a treadmill or gives you a like a little nuclear bump to your heart to see if it can handle stress and still pump out blood. That's the whole thing. But CTA is going to be more specific to like acute heart disease rather than stable chronic heart disease. Another test that people do is carotid IMT. So it tests for the intermedia thickness of your carotids. And what's happening is that if it's happening here, it can happen anywhere else in your body. If it's happening here, it can happen anywhere else in your body too. Usually for carotids, we're looking at brain for stroke prevention. But what it does is it sees if the vessel's stenosed or if it's hardened. It sees if the intermedial thickness, if the inner layers are too thick and causing occlusion. What we want is just nice open arteries. And the big thing about doing these tests is to say, do we want early intervention or do we need intervention at all or more acute intervention? Like
Okay. That is a phenomenal question.
Great question. And two, the answer is yes. I would go get it. And yes. And I'm sure it is fine. I'm sure there's nothing to worry about, but I think for peace of mind, yes. And go ahead and start taking precautions now with an aspirin. Pycnogenol is just a natural version of aspirin made from pine tree bark. Both work very similarly.
Wonderful question, Andy. Thank you for walking us through that.
Ben, you're welcome.
Jake, I see you. Angie, I see you. We got some familiar faces in the building tonight. Thank you guys.
Do we? Jake is in the house?
Jake is in the house. There we go. Thank you, Mary. I see you. I see your question. My battery's about to die. We can grab that over there. Sorry, my computer battery's dying, so we're trying to do a little quick charge up here. Rachel, I see you. Danny, I see your question. Thank you so much. All right, guys, we're going to the live portion of the show as we transition chargers. And we have one more Lyme question, I believe. I'm going to get to that real quick. See
Who's in the background? Was that Mom?
Little elf in the back.
Who's that little elf in the shelf? Is that Mama B?
Yeah, for context, guys, I saw the charger I had on my computer. The charge is going down, and that's not what it's supposed to do when I have a charger in. So we're figuring it out at the moment. All right, we've got one more question around Lyme, and then we're going to get to the live portion of the show. I'm going to put this up for you, Andy. Thank you so much. All right. I was wondering if there's a holistic
Mm.
treatment for Lyme. I just tested positive. I contacted it within the last 30 days. For context, I also have MCAS, so I have to be cautious with meds. They want me on doxycycline, 100 milligrams twice a day. I also do red light and infrared sauna to try to detox it out. What's your thoughts on this?
That's a really good. These questions are
Yeah,
good.
yeah.
And they're okay. So there's a lot of buzzwords. We like to do buzzwords: MCAS, doxy, red light, infrared detox, and Lyme. Okay, so Lyme disease, tick-borne illness. So with a tick-borne illness, what they do is they spread these spira sheets, and they can wreak havoc on your immune system, and you can honestly have more of like a sequelae of symptoms that it can almost last for years. And two, it can be really hard. People can have chronic fatigue. People can have crazy amounts of joint pain. Lyme disease is no joke. This is just Andy's opinion. If this were happening to me, I would do that doxy with no questions. I would treat as early as possible. What happens is that a lot of people don't know they got bit by a tick or may have been bitten by a tick 15 years ago and now they're having symptoms. Treating early because that stuff likes to lay dormant. A lot of that stuff with Lyme, with COVID, with HSV, with herpes simplex virus, like there's types 1 through 6, like they just kind of hang out in the dorsal root ganglion. I'm pretty sure is where HSV lives. I don't know where Lyme lives or where COVID hides, but that stuff are good lord, mono hides. All that stuff hides and can reactivate later. I would treat I would treat and treat as aggressively as possible. MCAS is mast cell activation syndrome. It's a very hyperactive histaminic response. So sometimes it can be very difficult to have meds on board because you can have histamine reactions. You can have abnormal or bad reactions to both medication, sometimes food, and you need a lot of antihistamine support for it. The original question is there a natural treatment? Yes, there are any natural treatments. There's this guy, I would encourage you to look at it because I don't know his protocol off the top of my head. It's extensive, but it's Dr. Horowitz, and he is the Lyme Institute. He has his people travel up to see him. I would see a Lyme specialist for this, and I would really even if you don't have symptoms right now, I would treat it aggressively because that's one thing that is really hard to see later on when it's 10 to 15 years down the road and nothing was done. So I think I would treat it aggressively as possible. Horowitz has something called a double dapsone protocol you can look up and you can see pictures of it online. It has all the naturals listed in addition to prescriptive medication. The double dapsone protocol is intense. It's very intense. It is Plaquenil or hydroxychloroquine. It's rifampin. It's dapsone, which is not a malarial. It's a leprosy drug. It also includes doxy and nystatin. I'm pretty sure nystatin, but it also shows all the naturals you can do too. It's all together. So I would look up Dr. Horowitz double dapsone Lyme protocol and see the images and do most of those naturals. If it were me, I would probably work with a Lyme specialist or someone who really knows what they're doing with Lyme. There is a treatment center here. There's a company here in Knoxville that does some IV therapy that comes out of Australia. I'm pretty sure Margot's new company, that Margot who used to work with us, who's brilliant, does some IV therapies for it, which is amazing. So that's another place that you can check out that's local in Knoxville. I don't know the process of how that works out, but I've heard great things about it, but it is an IV specific therapy to the bands that you test positive for. With Lyme, there's specific bands that come on a lab that show you basically what type, how aggressive, and how active is the Lyme. So if it were me, Yes, look at the naturals there. Red light's amazing. Infrared's amazing. Detoxing it out is great. Supporting all the systems that do detox. So anytime we're trying to get rid of something, breathing, sweating, urination, and defecation or bowel movements. That's how you get rid of waste. So you want to make sure all your detox is out. There's also something too called Cellcore. Cellcore 2 for chronic Lyme, you can do a comprehensive 6 to 9 month course of all natural treatments for something like Lyme. So there is something that is completely natural as well. So look up Dr. Horowitz, look up Cellcore comprehensive protocol. Um, Consider doing Doxy or something like it. Methylene blue is another one that people use all the time in higher doses, and I know that's on the Horowitz protocol.
I have to ask, is it, how big of a deal is it that they contacted it within the last 30 days, catching it that early? Is that,
It's
is that,
amazing.
okay,
Huge deal. That's amazing that you're catching it early. A lot of people think they got bit by a tick years ago. That's
okay.
usually the story you hear. So catching it within 30 days, yeah, that's amazing. You're catching it early. I would continue with treatment and come up with a plan.
I see Josh Davis from TriStar Strength and Rehab is in the building.
Nice. I'm looking
Josh
at the
is shouting
comments.
out our mustaches, and he loves
What does it say?
the mustaches. He's on Instagram, and he says, "Stashes are
Ooh.
strong right now. Vibes."
Yes, 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 yes. Oh, fine.
I
Oh,
love it.
I love that stashes are in.
They're in right now. Real quick, this is the same patient. Uh, does your clinic treat by phone appointment or only in person?
Yeah, we do both by phone. We're in state for Tennessee and Virginia. So that's the
Yeah.
only thing. Sometimes, too, for out of state patients, we can't prescribe out of state, but we can recommend naturals. So that's something that people will just ask for counseling on some of these recommendations, like Cellcore. Um, we can easily do if it's out of state. And what if symptomatic but tested too late? Hey, never, I say never too late, Sandy. Never
Okay.
too late. Trying something is a yes. And two, just kind of knowing what you're targeting. So if you're symptomatic, yes, trying it out is great. And finding either something that is close to our Horowitz protocol. Now, we're not Lyme specialists. That's not something that we specialize in. We can dabble in some of it. And a lot of the lighter cases, people do great with. Sometimes you can just throw things in. Low dose naltrexone and ivermectin are kind of silver bullets with that. So there's things that we can try that help people regain their immune system. And a lot of it is if you get your immune system up, it doesn't have a chance to reactivate. The whole purpose is to really beef up your immune system. When your immune system is down, that's when hidden viruses can come back out. Or during times of stress, that's like shingles. Shingles is chickenpox reactivated, and reactivations come at times of stress.
Thank you, Sandy, for letting us give some context there. I'm going to put this up from MY Debs. MY Debs, you're here for the best part. We're going live. We're going live questions. You were here just in time. And I see you got a great question. Thank you so much. You're here just in time. Let's get rocking and rolling. We're at the live portion of the show, ladies and gentlemen. Angie, you ready to get some live questions?
Ben, your enthusiasm is one for the record books. I don't know. I thought I was enthusiastic. I'm pretty enthusiastic. I can get there, Ben. But like, I mean, is this like the Tonight Show? Like, what is happening? I love it. It's
Uh,
amazing.
hey,
Let's bottle that up.
you know what? I'm ready to roll. I see H. Buckland over here on Instagram. I'm going to have to just read this out for you, Ange, because I can't put it up on the screen.
Sure.
H. Buckland is asking thoughts on Mounjaro use for sugar control and weight loss. FIL prescribed and seems to be only losing muscle mass, but not body fat. FIL, I'm not sure if I know what that is. You might, Andy. And if you need me to repeat that, I can.
So is Mounjaro good for blood sugar and weight? Absolutely. Yes. So Mounjaro, that's also tirzepatide is the molecule. It's a incretin hormone that hits GLP-1 and GIP. So those work to sensitize insulin, to decrease food noise, ghrelin and leptin, or ghrelin and CCK while increasing satiety, which is leptin. It's a no-brainer. Usually see less muscle wasting with Mounjaro or tirzepatide. It might be dose dependent. So sometimes too, and Robin, if she's still here, she loves a good microdose. And with microdosing, you might notice that you get the benefit of blood glucose control, weight management, but retain most of your protein or most of your muscle. What happens sometimes is that if Manjaro cuts your appetite too much, you won't eat and you need caloric intake, and your body is going to burn something for fuel, and it's going to burn muscle, fat, whatever it needs to. So you want it to burn fat, you don't want it to burn muscle. And we want to support and innovate the muscle by doing optimal protein intake. So really, really increasing your protein intake. I don't have the exact number of what you need. Some of it's patient dependent. Our nutrition coach Lucas takes people through that all the time. But increasing protein, yes to Mounjaro. Consider doing a compounded tirzepatide so that you can microdose.
And I just got confirmed here from H. Buckland. It's father-in-law. So FIL means father-in-law. I should have caught that. So it seems that father-in-law prescribed and seems to only be losing muscle mass, but not body fat. Okay. Thank you, H. Buckland, for that. And then I want to go to Stokes. Stokes has been with us all evening, so thank you so much for hanging in there. Question is for women in early 40s and testosterone coming back mid-20s. Okay. For women in early 40s, and testosterone coming back mid-20s, is that considered low? And what is the normal you should be at with taking testosterone or not taking any? Some doctors say it is low. And if I need to repeat that, I can.
That's good. That's a good question. So anywhere, it depends on the lab, Quest, LabCorp, what their range of normal is. Usually the range of normal is anywhere from 2 to 45. So she's like right there in mid-range. Technically, how I explain it is that it's not low in a lab, but it can be higher. And the good part and the beautiful part about testosterone for women is that it's already low. It's already lower than what we would do with replacement. So my two-part answer would be like, yeah, that's normal for age. That's not terrible. It depends on how symptomatic she is. If she wants to get it higher, then intervening and replacing the hormone is absolutely um feasible, and to getting it closer to about 80 to 100, sometimes higher, 150, sometimes lower at 60. It really depends on the female. Some females feel really, really great at 60. Some females feel really great at 100. Some feel closer to 200. The higher we push the testosterone, the more chance we have of side effects. So with side effects is, I say anything it can give an 18-year-old male, it can give to you, good or bad. So sex life, energy. I can work an after school job, play football, get hit in the face, bounce back, have muscle, eat garbage, and still be ripped. That's 18-year-old male. Scraggly hair, weird oily skin, a little bit moody. That can also happen too with higher T. So a lot of it is playing this little bit of a balancing game of what feels right for the patient. So mid 20s and early 40 years old, yeah. You don't want to give testosterone to a female who is going to become pregnant. So that's something you want to look out for and make sure that protective measures are taken in case she starts it. But look for 80 to 100 with relief of baseline symptoms.
All right. Thank you, Stokes, for that question
It's a
over
good
there
one.
on Instagram. Let's get to, let's see, I saw one up here. I'm going to go to YouTube from Jay. Recent preliminary research has shown an association between long-term melatonin use and a higher risk of heart failure. What's
Oh,
your thoughts
yeah.
on that?
Okay, that's a great question because I've heard that too, and someone brought it up. I looked at that. This is not recently. I think it's an association. So whenever there's an association, they usually do retrospective studies where they're basically looking at people who have had heart failure and seeing how many of them were on melatonin versus not. It's almost like you look back, and I believe that data was like a 5-year retrospective look. So you get a lot of data points, but usually doesn't necessarily mean causation because there's some compounding factors that come into studies like that. Like if they're using melatonin, they also probably are suffering from insomnia. And if we don't know the underlying cause of why they're suffering from insomnia, that might be obstructive sleep apnea, which would may be the risk factor for heart failure, not melatonin. So if someone with obstructive sleep apnea also took melatonin, also had heart failure, it's not the melatonin, it's the OSA, it's sleep
Mm,
apnea. So a lot of that to me doesn't mean causation. It does make you think. So the encouragement for me with this particular study is to do placebo-controlled study. That's a little bit tough to be like, are we going to find more heart failure with melatonin use, especially when it's over the counter? What this to me means is maybe use it more with caution or just as needed and not every night. Melatonin's also got some other great benefits too. I've even read too that sometimes if you use that melatonin, it makes you make less of your own. When it's over the counter, it's a little bit tough because the risk benefit of you sleeping versus not sleeping is also too going to increase your risk for disease as well or chronic conditions. So my thoughts are I think we need more information. I wouldn't necessarily stop using melatonin. It's a retrospective look, so there's an association but not causation.
mm.
That's a
Uh,
lot of buzzword. These are good questions. It's a
Jay,
good.
thank you for that. Thank you for that
Yes.
question. I want to get to Jerry in the UK. What's your thoughts on bee venom for cancer? Had single mastectomy, but now has spread to my skin and my abdomen. I've tried ivermectin, but not
Jerry,
much
I'm so
changed, just
sorry.
dried up slightly.
Yeah, I'm so sorry. I don't know much about bee venom. Honestly, I wish I did. I've heard it being used, but dosing response to treatment, I'm not as familiar with. This may be one that we pin to see if dad knows anything more. But I'd say too, if it's also like, I would be careful with it. I'd be careful with that one. But I know people use venom for
Yeah.
different things. That one I'm not as familiar with. Maybe maybe also looking at everything else in addition to that.
Mm,
Artemisinin, if there's been no radiation, um, fembendazole instead of ivermectin, playing around with dosings. So dosing for ivermectin can be, if it's ingested, can be upwards of 1 milligram per kilogram, watching for change in eyesight. Fembendazole can be upwards of 444 milligrams taken daily. There's also mistletoe.
mm,
Mistletoe's under not just mistletoe. What is it? No, tinsel. Not just
tinsel.
used for holiday. Tinsel, not just a holiday decoration. Can I get some of that tinsel? We're quoting the Santa Claus. Um, but mistletoe is used quite frequently and has good success. Apparently, like 50% of the people who have had cancer in Europe use mistletoe. So
That's
that's
super
something I'd
interesting.
consider too. Um, but skin, if it's single mastectomy cancer that's spread on skin, so if it's topical ivermectin, maybe using topical plus oral. Um, but two, if you find out, if anybody finds out more about B venom, let me know.
If there's anyone here in the comments that has any information on bee venom or has known somebody who has tried it, put in the comments for Jerry here, and I'll be on the lookout for it, Jerry. I'm going to put this up from Danny. Danny's been patient with me. Thank you.
Yeah.
What does the echocardiogram show?
So too, this is probably piggybacking from our big heart conversation of CT calciums, CT angiograms, and then carotid IMTs. An echocardiogram is an ultrasound. So it is using just an ultrasound probe. They do this something called an apical view. So they get underneath the heart, maneuver it so that you can see it pumping. So it basically shows the live action pumping of your we look at it for valvular dysfunction, so you're looking at the valves, the atrium, the ventricles, to see how each of those four parts of the heart, if it's pumping to the different chambers accurately. So an echocardiogram can see if there's reflux, if there's backlogging of blood, it can or prolapse. It can see basically what the valvular structures look like. So I think of echo more of structures,
Mm,
and two, how efficiently is it pumping out blood. So it gives you a percentage or an ejection fraction. So I think that's another great, very non-invasive test to do. It's usually not standard as part of like I would consider a CT calcium more standard of part of anyone's holistic care, anyone's preventative care can get a CT calcium score or carotid IMT. I think getting into echocardiogram or CT angiograms is if something is off on those initial tests.
mm. Danny, thank you for letting us talk about
That's
that. That's a
great.
great
That's
question.
great. Yeah.
Let's get to Mary Susan here. Please talk about
Yeah.
using red yeast rice for
Yeah.
lowering cholesterol.
I had a patient today that's starting red yeast rice, anywhere from 300 to 600 milligrams. It is I call it a natural statin. It works very similarly like a statin works without the negative side effects. So a statin works by blocking the enzyme that makes cholesterol, an HMG CoA reductase inhibitor. So it inhibits that enzyme. Red yeast rice works similarly to that. It's just to me a little bit less potent, so it's not as harmful. With statins are okay. You just have to choose the right one, and you got to do it if you really need it. So some of the statins just they target all cholesterol, like the sterols in your cell membranes. Your brain's made of cholesterol. Only a few don't cross the blood-brain barrier. Some are hydrophilic, I believe, and non-hydrophilic. So red yeast rice is a little bit safer option, but that's what it does. It typically blocks to my understanding, it blocks the enzyme. And it's a
Uh,
good one. 300 to
yeah.
600 milligrams. Life Extension's a great one. A great brand. Thorn, Now, Solaray, Pure Encapsulations. Those are really good brands to look at. And then I would test it. Test your theory. I think it's great. Also look at bergamot for cholesterol. That's another good natural.
Thank you, Mary, for that question. That helps more than you, I promise. Let's get to Karen here. A year ago, I was hospitalized for E.
Karen!
coli
It's so good to
and
see
sepsis.
Karen. Sorry.
Yeah. Uh,
Hey, how's it going?
Karen, thank you for being here as always.
Yes.
A year ago, I was hospitalized for E. coli and sepsis. Discharge note included kidney damage. Is this permanent? Since then, my labs show elevated BUN and BCR and abnormal GFR. Following high protein diet seems to be conflict, and I'm drinking plenty of water, but advised to drink more. Any suggestions or advice? This illness also seems to cause AFib within 6 months, but complete a successful heart ablation. What about the kidneys?
Oh,
Karen, we're
Karen.
super sorry. Um,
Yes. Oh, I'm so sorry about that. No, that's awful. E. coli and sepsis, it wreaks havoc on your body.
yeah.
That does. And kind of how we talked about earlier with detoxification symptoms, like if there's sepsis in the body and we can't get rid of it, then the things that are trying to get rid of it, your kidneys, gut, skin, for sweating, your temperature regulation for sweating, breathing, some of that too, you're going to try to find a way to get it out. And it might be that your kidneys are trying to help you get rid of it, which too cause some damage. Two, I don't know permanence or not. I always think that the body is very good at regenerating and very good at reversing damage. So I wouldn't say necessarily permanent with E. coli and sepsis, maybe, but I don't think it means that your kidneys technically are shot, if that makes sense. If you wanted, maybe looking at more of an anatomical view of the kidneys might be a little bit more helpful than just labs. So what the labs that you did, BUN is blood urea nitrogen, B/CR is a blood urea nitrogen creatinine ratio, and an abnormal GFR is glomerular filtration rate. A lot of the GFR is just a calculation based on age and gender. Um, Although I have seen people that drink lots of water have a much higher GFR. They're like the filters for the kidney, and the more they spin, the higher it is. And technically, it just means they're very well hydrated. What I would do in this is protect the kidneys.
Mm.
Typically with protecting kidneys, I know lemons are really good for kidney stone. Tart cherry is good for prostate. There's something else that's really good for kidneys, and it might be tart cherry for kidneys. But too, what we do is I think a low dose losartan or a low dose lisinopril, something that's going to block the enzymes. It's almost like a low dose blood pressure pill that's specific for the kidneys. I
Mm.
think too, Dad would be on a low dose losartan to protect them and just keep them nice and cushioned. That's how I usually describe losartan. So I think yes, plenty of water, high protein. Um, Yes, it is a conflict because your kidneys filter out proteins and can block some of the filtering process. So it makes your numbers look bad. I think that's a very old school way of looking at it. I'm not a nephrologist though, because I think high protein is good for your body. I would just be careful about how much. I just wouldn't go on a crazy high protein diet. But having protein in your diet, I think is really important for anyone in the aging process. Not that you're aging, but just anybody that's probably on this podcast, protein is good. A low dose losartan, I think, is great, or a low dose lisinopril. And this illness also seems to cause AFib within 6 months. I think it's just because your body went through a lot. I'm not
Mm,
surprised by that. I don't know correlation specifically with sepsis and why it would cause an irregular AFib is atrial fibrillation. So that is an abnormal electrical conductivity of the heart. So they call it an irregularly irregular heartbeat. And what happens is that if you don't get the blood flowing like you need to and a regular bum 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 bum, if it's bum 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 bum, it's irregular. Blood doesn't get shut out like it needs to and can start to pool and clot and can throw clot. So that's the
mm,
big deal about AFib. With a heart ablation, sometimes what they do is they basically burn a part of the electrical conductivity highways or pathways in different nodes so it doesn't cause that, which is really great. Our moms had an ablation before and did great. My big thing for you is protect those kidneys, hydrate them. I'll try to look at more naturals and see if we can send that to you. Part of me feels like it's lemons, but I need to see really what that is with it. And I would consider just a low dose losartan just to baby your kidneys.
mm,
I wouldn't be scared of high protein. What I would also too is encourage anyone looking at your labs to draw a cystatin C and a red blood cell magnesium. Those are two other tests that are very specific to kidney health. And it might be that those are fine. If cystatin C and red blood cell magnesium are fine, there is no kidney damage, in
mm.
my opinion. So take a look at those.
Karen, thank you for that question, and Andy, thank you for that answer there.
Yes.
Karen, we're thinking about you, and keep us posted with how everything is going. I want to make sure we get to a few more guys. We're running a little bit out of time. Lisa, I've not seen your question yet. I want to get to Roel's real quick, and then I see we've got one on Instagram as well from Lau. Roel's
Oh,
asking,
great question.
is homocysteine blood test a one-time test, or do we check it often? Like APO little a is a one-time test.
That's a
Yeah.
great question. So homocysteine, I usually describe this as a red blood cell inflammatory marker within the methionine pathway, which too tends to get elevated if there's a methylation issue. And if there's a methylation issue within anytime there's a pathway that makes something, if there's a kink, then things can build up over here. So it's like kink, build up, kink, build up. And that's what homocysteine does and can tend to be very inflammatory to the body. Treatments for high homocysteine are trimethylglycine and methylated B vitamins that typically helps bring that number down. Well, I would say only check it if it's high once. If it's high once and it's come down, it's not something that needs to be routine. Typically, people will test this once a year if they do repeat Clevelands. For me, if it's never an issue, it doesn't need to be part of a standard blood test. I think that's a spot thing, or more specific if it's hyperhomocystinemia. The other one, what? Sorry, Ben, can you put that up,
Oh,
Ben?
sorry. Yep, there we go. The APO little a is a one-time test. Are you seeing that? Looks like he froze. Andrew, you there? I think Andy might have froze on us, guys. Let's see if we get him back here
Am I
shortly.
back? Am
You're
I
back.
back? Okay.
You're back.
Sorry, that was crazy. The lights flickered. So those two other ones, lipoprotein little a and apolipoprotein B, those typically are apolipoproteins are like helpers. They're like the Gretchen Wieners to the Regina George. They're like the helpers to the main people, LDL. And so, too, if those tend to be high, those are more inherited genetic risk factors for hypercholesterolemia or high LDL. So with those, you're right. One-time tests, like you don't really have to recheck those because those are just going to be kind of elevated or not elevated. Some people really try to work on those, but I try to encourage people to look at the whole picture. Homocysteine, look at the picture with MTHFR, B vitamins, and your inflammatory cascade of high sensitivity C-reactive protein, LPPLA little 2, and myeloperoxidase. With apolipoprotein and apolipoprotein B and lipoprotein little a, I would look at what the cardiovascular risk score is with the CT calcium. So seeing what it looks like would determine how often you need to check it. But to me, that's not standard routine to check every 6 months.
Mm. Roel, thank you for that
That's a good
question.
question.
Yeah. Real quick, I want to hop to Instagram and get Lau's question. Thank you, Lau, for being patient with me. Would you recommend pelvic ultrasound to check for thickening while on testosterone, estradiol, and progesterone?
Wait, can you say that one more time?
Would you recommend a pelvic ultrasound to check for
Oh,
thickening while on testosterone,
oh,
estradiol, and progesterone?
great question. Okay, so testosterone can thicken the blood, but not usually the uterine lining. So it can increase hemoglobin hematocrit by making more red blood cells. With the uterine lining, estrogen typically likes to thicken it, and then progesterone likes to thin it. To my understanding, now too, it seems a little bit backwards because if you do too much estrogen, you can actually have some bleeding. And if it's not balanced by progesterone, progesterone comes in and almost like uh, thickens it up a little bit. So to me, I found a little bit of conflicting information about it. It's not routine to do a pelvic or transvaginal ultrasound, but we do it if there's abnormal bleeding with a pellet or with any hormones. So if you do any hormones or if you don't do hormones, what they say is that any postmenopausal bleed is cancer until proven otherwise. So I think getting a transvaginal ultrasound to see what the lining looks like is a good idea if you have the symptom of bleeding. So if the lining is thickened and there's something abnormal happening there, you're going to have a symptom. So I don't think it necessarily needs to be, and this is for women who have a uterus. If a female does not have a uterus, then a transvaginal ultrasound is not going to show you much. But I would say it's not going to show you much if there's postmenopausal bleed. But that's what we get concerned about with putting in hormones is, are we feeding some sort of uterine cancer that we don't know is there? Does that help out? So I would say look for a symptom and do it if there's a symptom. If there's not, then I wouldn't worry too much.
Lau, thank you for that. Ange, you got time for one or two more, and then I'll let you.
Sure.
I know you got to eat real quick. Sandy's asking, going to see Andy in December for pellet and to discuss probable diagnosis of non-diabetic ketoacidosis, monitoring with the Libre 3, eating increased protein and not purposely doing intermittent fasting now, less symptomatic but still fatigued. Any suggestions for Sandy here?
Yeah, that's great. Yeah, too, I would say if you're worried about ketoacidosis, so this is to hyperglycemia and dehydration turning the blood a little bit acidic. So there's something called beta hydroxybutyric acid that accumulates if there's not counterregulatory hormones keeping glucose low and hydration high.
Seems we might have lost Andy there for a second again. If I can get him back, I will, guys. I promise. Thank you, Lau. Thank you for that. Let's see if he comes back, and if not, we might have to table this, guys. Hopefully, we'll get him back in just a second. He might be having some internet issues.
I'm sorry. Can you see me?
Yeah, I love it. There's Bubba.
Hi, baby. So I'm sorry. We'll try to run through it real quick, Sandy, and we'll talk about it in December. But you can test, I would test for ketones. You can pee on a strip. There's a urine ketone strip. And then two, you can test by blood too, just to see if there's actually ketones. So non-diabetic ketoacidosis, you'll have positive ketones. So I would say Two, totally try that out and see what it looks like. Hydration's the big thing.
Mm.
Hydration is the name of the game if it comes into ketoacidosis. Now, two, non-diabetic ketoacidosis with ketogenic diet. Is that what we're looking at? Increased protein, not purposely doing intermittent fasting. But I'm curious about the non-diabetic part of it with ketoacidosis, because I
Yeah.
would say too, there's ketosis, which is just making more ketones in response to a low carb diet. But Sandy, my encouragement would be doing urine test strips, blood test, or a blood test. It will give you a number to say, are you making ketones or not? And then to increasing hydration, like a lot, increasing typical oh, baby. Typical hydration too is a pound per ounce of an ounce per pound of water. Like it's a lot higher than we think it is. Most people need a gallon a day, and we don't nearly get that.
Guys, we're going to do this one more question from Lisa here, and I'll give Andy a little context with Lisa, and then we'll let Andy go get something to eat. Real quick in the comments
Lisa,
while we're talking with Lisa here, could you guys give Andy his flowers? Let him know he likes to see it. He likes to see those 10s and the 12s. And
oh my God,
he needs to see it. He needs to just let him know how he did.
Do you know
Lisa's
what my
saying,
inspiration is?
Dolly.
Dolly. Hold on. Do you know what my inspiration is?
Dolly.
Dolly.
Lisa, thank you so much for being with us tonight. We've been thinking a lot about you and praying for you. Lisa got home from a hospital stay, 3 days in the ICU, very weak with muscles hurting. Is there anything, Andy, that she could do to kind of help build her back up in terms of kind of getting her muscles back? It seems that her muscles are aching a bit. And I might have lost Andy. Oh, there he is.
I'm still here. Yeah, I did get to read it, so we don't get cut off again. 2 weeks including, at least I probably need a little bit more information about what it was and why like usually when I think ICU and muscles hurting, I'm thinking rhabdomyolysis, like the breakdown of your muscles, to which usually the treatment is increased hydration.
Okay.
But to build you back up from just any hospital stay.
He'll be right back. I think. And you with us? Is he with us? He'll call me. Oh, there he is. Lisa, he'll call me if there's to finish out this answer, I promise. Hopefully he comes back here so we can all see him. There he is.
I'm so sorry. Okay, Lisa, before it cuts off again, okay, because something's in this house. It just kind of depends on what you were there for. I would say increase your hydration, be very kind to your body, get back to physically moving. I would take walks and get outside. Being in cold air.
I love this from Karen.
I'm so sorry.
Ben, your face is great every time Andy freezes.
I'm so sorry. Am I freezing? Because I disappear whenever it is. I'm sorry.
Let's finish up for Lisa here, and then we'll let you go grab some dinner.
Epsom salt baths, really good hydration, being kind to yourself, eating really, really well, boosting your immune system, all that stuff works. If it's not better in about a month, then I would take a look and see what's happening. Whenever I'm thinking about muscles hurting, I usually think about rhabdo. So that's something, it might not be muscle breakdown, but the treatment for that is hydration. So you can also too get IVs. IVs are amazing. Get them.
Lisa, thank you so much for that question. I hope that helps a little bit. We're going to let Andy go grab some dinner.
I'm sorry I keep freezing. I don't know what this is.
Well, one, I want you to stay just in time for you to get some flowers here. Guys, can we give Andy Give him, be honest. He needs to see if he got a 1 to a 10, where it is. But I want you to be honest. But I give him a 10. Danny's giving him a 10. Jerry's giving him 100.
Oh, this is amazing, yo, Jerry.
And then Rachel's blaming me on the freezes.
It is Rachel. I will text you back. It's good.
Let's see here. I see Robbie's in the building too. Robbie, our mustache brother.
I'll never have a mustache as good as yours, Robbie.
No, we're just trying to be like Robbie. That's what we're doing. That's the storyline. Is we're trying to look like you, man. Karen, thank you. Sandy, thank you. Guys, as you guys know, we do this every Tuesday, 7 to 8. We answer all your health and wellness questions. I'm going to run through the comments after we call it an evening and make sure I didn't miss anybody. If I missed you, I really apologize. Thank you, H. Buckland, for that. Thank you so much. Andy, go get some dinner, man. I love you. Thank you so much.
I don't believe in eating anymore. No, I'm done.
I'm stuffed.
Thanks. I'm stuffed. I had water 10 hours ago. I'm stuffed. No, I'm going to eat some pork.
We're going to get some protein. Ange, I love you, man. Thank you so much.
Hey, I love you too. Bye, y'all.
Guys, Brad, take us away.
Don't go away.